thiết kế kiến trúc là đương đại, tân cổ điển.
I'm living close to Venice,
Và tôi
and
ở
1
rất
hour
gần
by
Venice.
car, 40 minutes more or less. Okay,
Và tôi
and I'm
vẫn
teaching
thường xuyên đến
University
thăm
of Ferrara.
Venice.
This is also
Đây
close
là
to my city.
cái
It's 1 hour
trường đại
by
học
car.
mà tôi
So
làm
Ferrara
việc
is
đó.
here, the northeastern part of Italy as well.
Đây nó cũng
And
là
it's
một
an
phần
old
của nước
university
Ý.
founded in the 13th century. So I started
Tôi
using
đã bắt đầu sử
Miniscule
dụng
Scalar Guide
Miniscule
many years
rất là
ago.
nhiều năm
As you
rồi.
see, I published this
Và các
paper
anh chị
in
hãy thấy là
95,
có những cái
in
bài
which
báo
I
của tôi
published
là
a
đăng từ
technique
năm
to insert
1995 rồi.
implants and miniscules in the
Và
palate
ở đó là tôi đã có những
without
cái thực hiện
going
gắn
into the
cắm
nose,
implant
so
vào trong cái
without
phần vùng
creating
khẩu
fistula
cái
or any other problem.
để giải quyết
Now,
những cái vấn đề khác nhau.
I moved, yes, I developed the spider
Và tôi
school
đã
in the years
phát
20,
minh ra con
and
Vít
then as you see,
Spider,
the miniscule
một
that
hệ thống
started
Vít
very
Spider.
simple. Today we have
Ngày
a
hôm
lot
nay
of
là tôi
miniscules on the market and also on this system.
Và nó đã
You
được,
know, the
đưa
last
ra
one
thị
is
trường.
the angulated miniscules, as you see here.
Rồi những cái con
what
vít
I'm
này nó
talking
có
about,
loại là
I'm
con vít
talking
nó có
about
cái
rationality.
góc ở cái
What
trụ
is
của nó.
rationality? It's ability
Thì cái
to
ngày hôm
use
nay
among
là mình sẽ nói về những cái lý luận nào trong cái quá trình mà mình điều trị nông hàm trên với Miniscule.
to select what we think is the best for us. So it's a property of processes with the logic. Okay.
Thì đây là chúng ta phải
So
tiếp
my
cận một vấn đề
presentation
với một cái
will
cách suy nghĩ
focus
nó
on
rất là logic.
application of the system to expand the maxillary.
Thì đây bài báo ngày hôm nay á, là phải nói về nông hàm trên, nông xương hàm trên ở người lớn mà không cần phải có phẫu thuật. Thì tôi sẽ nói về cái hiệu quả của nó, nói về những cái điểm nào và những cái tác dụng phụ không mong muốn của nó. Những cái điều, những cái tác dụng mà mình không hề mong muốn. Và cuối cùng á, là chúng ta sẽ phải có nói tới cái khái niệm á, là chúng ta sẽ cá nhân hóa cái việc mà cái khí cụ nó tụ lên xương của bệnh nhân. Và chúng ta sẽ nói về những cái thành công thất bại cũng như là những cái biến chứng. Thì cái bài báo đầu tiên là xuất bản về Murphy là được xuất bản vào Ki Chun Lee.
Who are here with us.
Và
So
ông Park,
they opened
ngày
the
nay
eyes
hai
of
người
the
đó cũng có mặt ở
orthodontists
đây
in the
ha.
world because they said, oh, look here.
Mà nói là hãy nhìn nè, các anh chị có thể nới nông rộng xương hàm trên, thậm chí là ở người lớn nữa. Thì đây là cái cách mà họ đã làm. Thì cái cách này nó sẽ là cái cách tốt hơn là những cái cách mà trước đây chúng ta đã từng làm. Và họ sẽ đặt cái tên cho cái khí cụ này là Murphy. Và đây là cái cách mà sử dụng. Thì đó nó là một cái khí cụ được chế tạo trước ha, nó có 4 cái con vít. Thì chúng ta sẽ biết đó là liệu Murphy thì nó có hiệu quả hơn Sharpie hay không, nghĩa là có hỗ trợ phẫu thuật hay không. Thì Murphy nó sẽ cho thấy là một cái sự nông rộng xương theo chiều ngang ở tầng mặt dưới, ở tầng mặt giữa, và nó sẽ nó có hoàn toàn có khả năng làm được với một cái lượng nông rộng theo chiều ngang mà tương ứng với lại Sharpie, nghĩa là không cần phẫu thuật nhưng mà đạt kết quả được tương ứng. Thì Murphy thì nó sẽ nông rộng cái xương theo cái hướng song song nhiều hơn, theo cả chiều ngang lẫn là cái chiều mặt phẳng đứng ngang và mặt phẳng đứng dọc. Thì Murphy nó có rất là nhiều cái ưu điểm. Bây giờ khi mà chúng ta nhìn vào một cái bài báo khác, họ sẽ nói là Murphy có vẻ như là đưa đến những cái thay đổi trên lâm sàng một cách đáng kể khi mà chúng ta so sánh hiệu quả của nó với IEP hoặc là Sharpie, và nó có ít cái kết quả xấu, kết quả tệ trên lâm sàng hơn, nhưng mà Murphy có phải. Cho nên Murphy nó đã trở thành một cái lựa chọn đầu tiên mà chúng ta nghĩ đến khi chúng ta cần lớn, nhưng mà chúng ta cần phải cẩn thận tất cả những cái tác dụng phụ của nó. Murphy cũng như các khí cụ khác rồi, nó sẽ có những cái nó có những cái tác dụng phụ của nó. Ví dụ khi mà chúng
Then we have different types of approach. One is appliance driven. We have our appliance, we put them, we connect the appliance with the teeth, and then we expand. Okay? So it's a teeth connected standard appliance we put there, finish. But there is another concept, it's a bone-borne driven appliance. So we want to expand the maxilla, not relying on this type of appliance, but rely on the amount of bone we find in each individual patient. So it's an individualized approach. When we apply MARPE, we have meniscus applied in the palate, okay, and we connect with the teeth. Of course, when we activate, we are going to apply a lot of forces, we saw before. Can be 4 kilos, 3 kilos, 10 kilos, and so on. What happens with the meniscus? The meniscus are not integrated. So what they do, they move outside. We have a lot of research that says that. So by moving the screws in the lateral direction, what happens to the teeth? They are connected with the MARPE. They cannot stay where they are. They are going to incline, of course, and they're going out a little bit, of course. Okay. So sometimes we apply forces that sometimes they bend the meniscus as well in order to be successful. So what happens to the teeth? The teeth can have even some fenestration. In young people, we can recover very suddenly. Adult people, we know that the periodontium is not capable sometimes to recover as we would like. And then suppose you have this patient with a narrow palate, with a thin periodontal support, okay? You see how much thin is the buccal bone in the molar area. And you see the level also, the level is very high because this patient lost the periodontal support before, okay? And there are many because when we have narrow palate, normally what we have periodontal support, okay? So if we now apply an appliance like that, we start to expand, what happens? It happens that we are losing thickness in the bone, in the buccal bone, and then we also losing the height of the buccal bone. So this is something that's been described in the literature, because more important is, as you see here, in which he described that, in conclusion, the incorporation of teeth into bone expander resulted in increased severity of side effects. Okay, so we have high loss and formation of diseases. And there is also other studies, as you see here. This is systematic review. We have decreased the mean buccal bone thickness and also loss of buccal alveolar height. That is something that I don't like to have in my patient. So even, especially today that we are talking a lot about patient-centered orthodontics, I don't want to create problems to have advantage and have drawbacks or unwanted side effects. So therefore, the University of Ferrara, we created this is a digital planning research institute in which people are focused on all the digital technology applied to different fields in orthodontics and also to skeletal anchorage, okay? And we thought we want to expand maxilla, yes, because this is a wonderful idea, really. But we want to do it without touching the teeth. We won't rely only on skeletal anchorage. We don't want to touch the teeth, okay? So, here, the clinician can send their X-rays as they are fine, as you will see. And if you want, you can send and ask to plan for you, okay, this type of approach. So you can take also a picture of the QR score. But so we are using the big cortical concept because we are relying only on skeletal anchorage. We are not relying on teeth. Okay. So the forces we want, the forces are going to be dissipated for the meniscus. And there are several studies who demonstrate that if we have a bicortical anchorage, we have better stability, meniscus stability. Okay. So we want, basically, this logic to have better meniscus stability to be able to expand the maxilla. And when possible, we are looking for three cortical anchorage. These are sites where we have probably sometimes more bone than in the palatal bone. So why not to take advantage of sites where we have more bone. Okay, and we described this in 2022, and that's a patient. Okay, it's an open bite, it's a class 2, it's a cross bite. Okay, we want to expand the maxilla and then correct the occlusion. And at that time, and this is one of the first cases, 2014. Okay, we planted the mini screws in this way. As you see, it's a strange way to plant them. Okay, but we are searching places where we have bigger amount of bone. Okay, so no tooth is involved, and because we wanted to apply the mini screws and the appliance in the single time, okay, we did an appliance like that. We were successful. Okay, so you see, we published the one visit concept in which we are applying mini screws and appliance in the same time, but not driven from the appliance, but driven from our planning. And this is the compensity before and after the maxillary expansion. You can see that the inclination of the molar is not changing at all. And also the thickness of the bone buccally to the first molar is always the same. That's something that we like, absolutely. So, there is also another advantage when we do like that, because the teeth are free, are not involved. We can start to move the teeth during the stabilization of this maxillary suture opening. Okay, and that's our patient before and after. So, for me, the rule number 1 is if you want to make an approach like this, select the proper places. Now, how can you apply the mini screws there? Exactly there. We developed a system that is called MAPA, Mini Screw Assisted Pattern Application, in which we are using digital technology. So we superimpose the CT of the maxilla to the compensity, and then we plan virtually the mini screws in places where we find the biggest amount of bone. And then when we have that, we create a guide. And by a guide, we are inserting the mini screws in the proper place. Is the lateral self-use? Can we do it in the lateral? No, because according to this study, it's important that we can do a lot of errors. I don't have time to explain. But the question is this really a really precise system? Could everybody use it, or do we need experience? That's the question. So we did a study at the University of Ferrara, and we published this year. Okay. The purpose is to see if the beginners, students of the first year of the specialty in orthodontics can do it by themselves or not, or if we need experience. So we take 40 models, 20 models, 40 screws, a group of 10 beginners and a group of 10 experts. We gave them the same model. We teach them the protocol because it's not a simple mini screw insertion, okay? And then what we did, we take all the models with the 2 mini screw insertion, then we put a scan abutment, and then we superimpose each model of each participant to the original one in which we plan the guide, okay? And then we superimposing, we did some measurement in the 3 plane of space. And we did that, you see here, 9 measurements in the 3 planes of space. At the apex, at the head of mini screws, at the angulation. And what is the result? That, of course, we were expecting some errors, but the beginners made an average error of 0.28 millimeters. That from a clinical point of view, what is 0.28 is nothing. Okay? Even the expert, they made some errors. Okay, they did 0.12. So the difference between expert and inexperts is 0.16. But what is the most important message of this research? Okay, is that the system is reliable, and we can perform also what we call one visit technique. So it means we can apply the mini screws and the appliance simultaneously, at the same time, at the same appointment. That's most important. Okay, for us, we want to do not 2 steps, but 1 step. Okay, I want to present another patient now. This patient is, Martina, and she is an open bite. She has a narrow maxilla. We would like to close the bite and expand the maxilla. The maxilla sometimes that seems to be very narrow, but if you look now, this what is with the CT, you see here, is really narrow in respect to the mandible. You can use different technique to measure the differences, but we see immediately that maxilla is too narrow. Another thing we see immediately, that the root of this patient, the upper maxilla, are not inside the bone perfectly, okay? Many teeth are a little bit outside. So the periodontal support is still buccally. So we want to expand the maxilla, yes, but we don't want to expand and provoke periodontal problems. Now, could we have failure? Or may we predict success? If we look at the literature, as we showed before, like it should be, okay, if we rely on this study, okay, they say that when we have a mid-satellite suture with these characteristics, probably we have failure. We need survey, okay. But is it really reliable, the literature, this kind of literature? If we look now, by the time of the literature, we have some changing. Because later on, 2021, this group of authors, they compared a group 25 patients in which we were capable to expand the maxilla, and then what they found, then they investigated the characteristic of mid-satellite suture. 17 patients that were successful. They had the mid-satellite suture characteristic B and C, that is predictable to be successful, but 11 of them, they were stage D again. So they concluded that the characteristic of mid-satellite suture is not reliable. Okay, but it's more important is the age of the patient, because when we increase the age, we have the increase of success. Another important thing is the amount of bone we have here. Okay, this is important. How much bone we have. So it means we need stability for the meniscus, of course, if we need a lot of bone here. It depends from the amount of bone. And we also can understand, we have to also point out that they are using a Marpe appliance driven. Okay, Marpe doesn't describe every kind of approach. Okay, so result is no, the mid-pattern characteristic mid-satellite suture doesn't help you. But I thought I have now all the information. And then if you look at the literature, in 23 there is another group, another research, and they said, again, no, the first one was not good. The second one was not. What is most important is this one, okay? Zygomatic maxillary and pterygomaxillary suture are the most important to look for, okay? If you want to have success, you have to look at. Okay, we have everything. But now, if we go to 2025, we have another paper. And this group, they said, oh, the majority of resistance is not there, okay? It's here. The pterygopalatine suture. So they give us another classification of this suture, and they underline that it's important the pyramidal process, how the pyramidal process is matching, okay, the pterygoid notch, okay. That is a very important area to look for in order to predict success and failure. So, if you mix together all the literature, we really don't know where to rely on. Okay. That's why we need what? We need expertise when we do that, okay? Because it's not always simple, okay? That's why at the university we said that we need a team that follow the literature, that look at the cases carefully, and they suggest and help you. Okay. And that's what we do today, because we want to have an individualized, okay, approach. In this case, Martina, this is the suture. If you look at the characteristics, what do you say? This is probably D, probably E, and probably it's a failure. But we do bicortical and tricortical. As you see, yes, in the tricortical, we are higher than the nasal floor. It is wrong if we go closer to the center of resistance. Depends what you want to have. If we want to expand the basal bone, the basal support, for me it's not wrong. for me is correct. Okay? So it depends what you want. So it's always an individualized concept. Okay? Orthodontics is always like that. Okay? So we describe the three cortical anchorage. I want to put the minuscule where we have much more bone, not where I have 2 millimeters of bone. Okay? Because for me it's more reasonable that if we have three cortical plates involved, I have better stability. And I can rely better on my skeletal anchorage. Or why do I use skeletal anchorage, not the other way? Okay, that is a slice of a combine, okay? And you can control if the minuscule is going there or going outside, okay, when you are using a guide, not when you put in the minuscules like that, okay? And here you see another thing. Okay, what we have? 2 jack expander. Any reason to do that? I will show you later. Okay, this is my patient, and then this the expansion, maxillary expansion. This point we transform a little bit delicate cases. I don't say difficult, but in moderate cases. So for me, in my hand, I can use now some aligners. Okay, I can treat my patient with aligners. I extrude the lower incisor instead of the upper one because this is gummy my tendency. Another important thing is that I can leave the meniscus in the palate. I can use my aligners. In the meantime, I don't block the teeth. Keep them moved. Okay, during maturation of the mid-palatal suture space that enlarged. Okay, that's the case. At the end, patient is happy. Okay. And this is what we want to have. We have a patient successfully treated, okay, from all different points of view. Now, this is the combine because this gives me more information. More information to compare the amount of bone we have buccally. Okay, I don't think I increase the bone buccally in this case. Okay, now, time is running, yes. So you can compare maxilla and mandible, okay? We really expand maxilla at size that we wanted. So for me, message number 2 is use sides with larger amount of bone if you want to expand the maxilla, okay, successfully with an individualized approach. But, of course, success and failure are very close. So you can really the ways to have success and failure are very close. Sometimes for minimum error, you can go to the failure way, okay? And we don't want to go in that direction. We want to have success direction. And you see, it depends from many things. Maxillary sutures, minuscules we are using, activation protocol we are using, appliance time, precision of the appliance and rigidity, because there are studies that demonstrate that if the appliance is precise and rigid, it's much better, transfer much better the forces to the maxilla. Okay. So, regarding minusculus, I'm using this one because it has a conic part at the beginning to overcome the disparallelism, and also we have also vertical walls that they can withstand to the lateral forces that when we want to expand it. Okay, so I like these 2 concepts. And today we can also rely on angulated minusculus because we want to insert the appliance very easily. Regarding the activation is a study from Wieslander and Walter, okay? And they published that if we don't apply too much forces and we go slow, it's better than applying high forces and go rapid. And this is a human being, it's not on animal study, okay? So today we should speak about not MARPE, but MASPE. Minuscular assisted slow palatal expansion. In fact, I'm using a slow protocol. I'm not activating 1 activation per day or 2 or 3. I do it 1 every 2 days, okay? Sometimes every 3 days, okay? And how much should we expand? We can expand a lot. There are some people that say we cannot expand more than 4 millimeters. You can expand a lot, but the expansion, maxillary expansion depends from the lower arch, remember. So it's the lower arch that give you the amount of expansion you need, okay? It's not the fact that you want to show big expansion. And also in this case, you see, we have a complete cross by the beginning, the mora, and then we have a resolution of the crossbite. We didn't influence the inclination of the upper molar. Absolutely, as you see here, we didn't influence also the thickness, the bone thickness backally. So, for me, this is very important. And here you see how much expansion we reach in this patient because this patient needed. Okay, 10 in the anterior and 8 in the posterior. Another important concept is that when I'm using miniscrews to expand the palate, I don't want to remove the appliance and remove the miniscrews. Why? To put other miniscrews to go over with the treatment. No, if I need miniscrews, I leave the one that I need. And during treatment, for example, in this case, I perform 2 extractions in the upper arch, and then I want to reinforce the anchorage, I can use it. Okay, why not? So I like a triple system, absolutely, because I respect my patient. Okay. And now, what's about this tandem skeletal expander? We did some research, but I want to notice, underline, that the first reason was that we developed because we want to go closer to the center of resistance. Because when we have narrow palate, the expander doesn't stay close to the palatal vault, it stays down. And we have a lot of lever. And when we have a longer lever, we have a bigger possibility of failure because the miniscus are moving too much and we are expanding the teeth. Okay. So I want to go to put my expander as close as possible to the palatal vault. So there's no space. We put one in the anterior part, one in the posterior. Okay. So, but there are other advantages. Easier to activate, we discover later. We don't need to apply big forces to activate. We don't need a special branch, okay? We don't really, okay? Very, very easy to activate. Third advantage, we can make differential expansion. Are your cases all symmetric? No. Sometimes I need to expand a little bit more the anterior part or the posterior. So at the end of expansion, I can also differentiate the amount of expansion. And these are the main advantages. So like I want to show this patient. Patient is an open bite, he came, is a lot of gingival recession. So if we have a lot of gingival recession, means that also the bone is down. Okay? We have many periodontal problems. The lower canine is out, you see. So now it's an open bite, we want to be treated with a surgery. This is cephalometric, okay, and this is suture, mid-atrial suture characteristic. So what can we do? What can we predict here? It can be difficult, okay. So we perform a miniscrew insertion and we plan the miniscrews as usually. We thought we want to have 6 because of the anatomy, of the characteristic of the other sutures, okay, 2 expander, and we expanded, and seems we have overexpanded, but it's not because now we want to intrude the teeth. And we want to use the same miniscrews that we used for the expansion, okay, we leave some of them, and then we are creating a system that inside we are using a bar, okay, and outside we are using plates, plates, and we are using, for example, miniscrews, straight miniscrews, conic one in the anterior, and angulate in the posterior, and we use the same miniscrews to treat the patient, and we didn't use any other miniscrews to do that, to control the open bite, okay, so we took in the lower, in the upper little bit, from the open bite we finish with a deep bite. Now we can intrude the incisors with a simple wire, okay? And we correct the gummy spine as well. So at the end, we have a total intrusion, okay? And this is superimposition. This is structural superimposition, okay? That's, you superimpose according to Bjorn. And this has cephalometric, structural superimposition, executorial superimposition as well. Now, okay, if you look now at the convexity, we see a really a major movement that we obtain in cases like this. Okay, and that is the combine 3 years after. You see that the bone maturation, there is bone inside the mid-sacral suture, and the size of our maxillary expansion is almost parallel. And that's a patient smiling at the beginning, at the end, they compare, very happy. So, is 3 cortical anchors advantages? So we thought we do a study. And we perform a study with a finite element analysis, okay? And we compare 3 cortical, bicortical, we compare MARPE with a single check screw and MARPE, or you want to call tandem, with 2 expander, okay? And we did this, and what we found, the amount of expansion is greater with 3 cortical anchorage with respect to bicortical. And second result is the 2 screw expander, the tandem, is generating parallel opening, both in the transverse and coronal place, promoting body expansion from the maxilla, and seems to be more advantageous in respect to the single one. But we did also a study on human being, and we are now publishing it, okay? And you see, because it was a work of a student at university, okay? And we did in 24 patients, adult patients, as you see here. And what is the result? It's effective in obtaining maxillary expansion, okay? No tooth is involved, okay? Parallel maxillary expansion, okay? And little or no effect on dental tipping, and no effect on the velar bone bending, and buccal bone thickness. And this is demonstrated in these cases. And the spatial outcomes appear to be independent from the vertical skeletal pattern, things that has been reported in another study, but also is independent from patient age. It's a small group, but this is our result. So rule number 3 for me, select the proper appliance, because really we found that there are some advantages with this appliance. But failure is not predictable. Okay, you cannot predict we have a failure. I have success. Cannot be excluded with certainty. So what we have to do as clinicians, we always have to have a plan B and a plan C sometimes. So we have to explain to our patient, okay? And what I'm doing, for example, this is a 48 years patient, okay? Periodontist sending it to me because she has a lot of periodontal problems. Okay, you see here, it's a lot of crowding. Okay, if you look at the panoramic, she lost 2 teeth. Lower, the amount of periodontal bone is there, is very, very poor. Okay, so would you like now to expand the maxilla? I like to expand because there is crowding. Do you want to expand to align the teeth, as the periodontist asked me? No, I don't want to expand the teeth absolutely in a case like this. You want to connect the teeth with the maxillary expander. For me, it's risky. So we thought we do it just using skeletal anchorage. Okay. Again, look at the combine. Look at the combine, and now she needs maxillary expansion. So if I'm capable to perform maxillary expansion, for me is benefit for the patient. Not only from the aesthetic point of view, but also from the health of the patient. So now we have to consider, this is the characteristic of mid-sacral suture. What do you do? So we have to take in consideration the age of the patient. Remember, if you increase the age, you increase the difficulties. Suture staging, okay, periodontal problems. So we have to select the proper mini screws, the number, type of appliance, and eventually explain to the patient that eventually we can use some adjunct therapy. There is only one paper that provides you some information about, for example, cortical puncture. This is an adult patient. If I do any cortical puncture, do I perform any mistake? No, we don't need to grow. Okay, the growth is finished. Okay, when the surgeon does the survey, doesn't take care. Okay, it's open the suture, cut the suture. So why not to perform some acupuncture? There are no other studies that demonstrate this effective, but we had, okay? So we do on board PS tandem skeletal acupuncture. So this is the planning. We are using angulated mini screws in the back, and conic straight in the anterior part in order to have a perfect fitting of the appliance. And then we have a guide to perform acupuncture without perforating the palatal nose, okay? And then we combine both of them, as you see. That is expansion, we are successful. Okay, then we treat the cases again with the liner and the lumbar. In the lower, we select the instruction for incisor, okay? And this is the case at the end, class 1, perfect thing at the end. And we aligned, we didn't create any periodontal problem. And the patient is 60 and is smiling again. Okay, that's what we provided, individualized with an individualized approach. If we have a failure, if we are capable to analyze the reason, remember, it's not a failure. Can be a step to the success. Okay, you can understand where you make a mistake and where you can improve yourself. So in some cases, we do acupuncture, and we do another thing, we do corticotomy in difficult cases, and we announce the patient. If we are not successful this way, eventually we do this. Okay, and this is another step to provide success in our patient. I'm going to take conclusions how, you see, transversal dimension with SAPE we can correct without SAPE. I call bloodless SAPE. This is our approach, okay? We can move, if you want, from the appliance driven to the bone driven, okay? I'm using the posterior part superior insertion side for a parallel and larger maxillary expansion. The tandem skeletal expander seems to be effective without drawbacks, and cortical puncture can be evident in some patients. But of course, we must, the first rule is not nocere. Be trained properly, study, and listen correctly. So I give you 3 messages to finish my lecture. We need to respect our patients, so think about that, okay? Because we are responsible for our treatment, okay? And so we have to propose to our treatment reasonable type of treatment. So it's rational type of treatment. Because our patients should be treated very, very precious thing. So we have to be concentrated in each patient and needs proper treatment. So I thank you for your attention. Thank you.
Thank you very much for your very